I'd like to introduce our next speaker. We're going to shift gears in the oral systemic spectrum and talk about the next subject, which is women's health and pregnancy. And we're so pleased to have with us Dr. Anita Showalter, who is from the Pacific Northwest University in Yakima and is a specialist as an OBGYN. Dr. Showalter is a graduate of Ohio University College of Osteopathic Medicine. She completed her OB residency at Cuyahoga Falls General Hospital in Ohio. Her private practice of 9 years in Wayne County, Ohio included many Amish and Mennonite patients. A focus on osteopathic techniques to reduce the need for other medical interventions was particularly welcomed in that community. She plans to research the use of osteopathic manipulation to reduce the complications of pregnancy, labor, and delivery, and to relieve the symptoms of chronic pelvic pain. Dr. Showalter's professional associations include the American Osteopathic Association, Washington Osteopathic Medical Association, and Distinguished Fellow of the American College of Osteopathic Obstetricians and Gynecologists. Other activities include chairing a committee to develop an osteopathic curriculum for obstetrics and gynecology residents, and lecturing on osteopathic techniques and philosophy in this specialty. She's been inducted into the Osteopathic Mentor Hall of Fame. Help me welcome Dr. Showalter from Yakima, Washington.
It's my sincere pleasure to be here this afternoon, and I consider myself a neophyte on this topic with a sharp learning curve. OBGYNs have known for a long time that inflammation was a very important part of our practice, especially in the realms of preterm labor. And most recently, in the literature, we've kind of given up on that. We've said, you know, if labor's going to happen, it's going to happen. The best we can do is postpone it a little bit to give the babies a better chance by getting some steroids on board to help with lung development. But basically, we've kind of thrown up our hands with that as far as inflammation goes. We have found a connection with progesterone to help prolong labor or prolong pregnancy in those prone to preterm labor, but we've kind of hit a standstill. I'm really wondering if this is not going to be that next frontier for us to start looking at the oral health of our patients to help solve some of these problems that have been enigmas for us. So first of all, I have no disclosures. I did add a little picture of our university in Yakima, Washington. We are the first new medical school in the Pacific Northwest in 60 years, opening our doors in 2008. We will be graduating our third class of DOs in a couple weeks here that we're very proud of. So if anybody is up in the Yakima region and wants to see our facility, we'll be happy to give you a little tour. So we're going to, I'm a professor, so we have to have learning objectives, right? We want to explore how to obtain a state of health with our patients, look at the conditions of oral health that are affected with pregnancy, to look at some of the complications that have been shown in literature to affect pregnancy that are influenced by periodontal disease, and also look at conditions in women's health. Then to develop strategies on how we can deal with our patients. As OBGYNs, we have a unique opportunity in women's health because women as a group understand the importance of health maintenance opportunities with their OBGYNs. It's often just called, I'm going to have my Pap test. It's a lot more than a Pap test. We do complete health maintenance exams and checks and talk about how to become healthier. So women are already oriented to using their OBGYNs for that reason. If we add oral health to that, I believe that we will take our patients to a new level of health. In OB, most of what we do is preventative. We're measuring fundal heights, we're checking fetal heart tones, we are watching for early signs of pre-eclampsia in our patients, but most of our patients are generally healthy and will have good outcomes to the pregnancies. I tell my students, I said, we're firefighters. We're there for the just-in-case times, but the truth of the matter is most of the time this process goes along as planned with healthy outcomes for both the mom and the baby. What we do want to do is identify modifiable risks in our patients, and that's what we can do to improve outcomes even more. And the other thing about OBGYNs is because we develop this relationship with our patients during the very intimate time of making that transition into motherhood, women often see us as their primary care provider. Even if they have a family doc, they'll come to us with other things that are going on, and then we can provide that level of care for them too. So it makes sense that OBGYNs are paying attention to the whole patient, including oral health. I don't know how many of you are familiar with osteopathic medicine and with the philosophy that we approach healthcare with. When I was exploring becoming a medical professional, I had the option of becoming an MD or a DO. Really didn't know much about osteopathic medicine until I actually started on the pathway into entrance into medical school. And when I learned about the osteopathic philosophy, my mind was made up. Really fit the way I saw myself dealing with my patients. So we actually have medical students that rotate in the Tri-Cities area at Trios. So you may run into some of our students here. And I just want to share a little bit with you about how we approach healthcare. The first philosophy of osteopathic care is the body is a unit of, the person is a unit of body, mind, and spirit. I think it's really important that we always look at the whole patient. We talked about anxiety and stress being risk factors for some of the chronic disease states. It's important for us to be watching for those kinds of things in our patients. It's particularly true when we're dealing with obstetrics. There's actually a normal physiologic process, and obstetrics is the only branch of medicine that's dedicated to a normal process. So we have to keep remembering that. Also, the body is capable of self-regulation, self-maintenance, and self-healing. A.T. Still, the founder of our profession, taught that it is blood flow, lymph flow, and nerve flow that creates homeostasis in the body, and the body was designed to cure itself. Given the appropriate balance of all those factors, you will have a state of health. The third, structure and function are reciprocally interrelated. That's why we use manual medicine while we're taking care of our patients, because if the body's structure is sound, then we also know that those important fluid flows, nerve flows, lymph flow can happen in a way that will help the body maintain homeostasis. When you're talking about oral health, the structure of the jaw is very important for appropriate function of the gums as well, right? When that starts to go, then you have other problems. Structure and function are reciprocally interrelated. And then rational treatment is based on the understanding of all of those factors, pulling it together for the patient. The founder of osteopathic medicine, A.T. Still, was famous for a lot of his quotes. My favorite one of his quotes that I tell the students all the time, and they get tired of it. They say, "You're not going to quote that again, are you?" And I don't apologize, because I want to hammer this one in, that the osteopath should find health. To find health should be the object of the doctor. Anyone can find disease. And I'm so excited about the tone of this conference that we are talking about finding health for our patients, not just identifying and stamping out disease. Now, we've also been talking about cats. So Dr. Still liked to talk about cats. He would tell the students, when you step on a cat's tail, what part of it screams? Okay? So when we are looking at our patients, we will see a symptom. And it's generally a symptom that brings a patient to our offices. But the symptom, if we only treat the symptom and we don't look any deeper, then that symptom may raise up again, right? So focus of this whole conference has been looking deeper to figure out exactly what's going on, find that tip of the tail, and not just treat the mouth, right? Preconception care is identifying factors in a patient that may be an issue if pregnancy occurs, and also preparing a patient mentally for the process of becoming pregnant and birthing. Now, I was just reading up on preconception care, and recommendations are that you don't just make special appointments for preconception care, that whenever you have a woman of childbearing age in your presence, you prepare her for the possibility of pregnancy, because even with all our contraception options, about 50% of pregnancies are unintended. That means the patient's not going to call you up for an appointment saying, I expect to be pregnant in the next 4 months. You need to take the opportunity when she's in front of you to talk about the issues that may be important in her pregnancy. The purpose of this time is health promotion. So we want to identify modifiable risk factors and take care of those before the pregnancy occurs so that you have optimal outcomes. This is an excellent time to screen for periodontal conditions and talk to the patient about her oral health. Dr. Lee mentioned that my practice in Ohio was with the Amish. The Amish don't use standard insurance plans. They pay for all their health care themselves, and their tradition does not place a lot of value on taking care of the teeth. They see it as more of a cosmetic thing, an actually part of their health. And so a lot of the patients don't brush very often. So I would get these young patients in with their first pregnancy. They might be in their late teens, early 20s, with beautiful teeth and awful looking gums. And I'd ask them, do you brush your teeth? And I had this one lady say, oh yeah, I brush my teeth. And I said, how often do you brush your teeth? She said, once a week. She was very proud of that, okay? So we had to educate her on better maintenance. Now, I knew back then that there was a connection between the teeth and health. I didn't realize how strong of a connection. But we need to take those opportunities to educate. And I had a friend who went to the dentist, and she said, yeah, we were talking about flossing the teeth, and he told me I don't need to floss all my teeth. Just floss the ones I want to keep. And I always remembered that. So that's a way to kind of hammer that point in. So you also want to encourage the patients to take care of any dental problems that are pre-existent to a pregnancy so that they can take care of those big ticket items before they get pregnant. We were talking, I was talking with some of the other attendees here about doing x-rays when you're pregnant. Dental x-rays are totally fine to do with a pregnant patient. You just need to properly shield them. With today's technology and the radiation that you use with very focused dental x-rays, you really don't need to worry about the pregnancy if you have properly shielded the patient. So you can reassure them. You want to know if they're pregnant so you get everything covered. But that should not inhibit you from doing your jobs taking care of that patient. Also, we like to use the opportunity in a preconception visit to talk about breastfeeding. Breastfeeding is very important for the infant's future dental health. And some of the things that breastfeeding does is infants will have better jaw and facial development, better muscle development, better tooth development, less need for braces in the future if they're breastfed. In today's economy, a lot of women aren't exposed to a lot of other women who breastfed their babies. In the Amish communities, everybody breastfeeds. It's the expectation that you're going to breastfeed. It is the rare person that chooses not to. They see the women breastfeeding when families are together. This is not a foreign concept to them. Even our patients that are very well educated and know or they know intuitively, or they have a knowledge base that breastfeeding is good, they may not be exposed to other women that are breastfeeding to get that help with just the kind of common issues that women might come across. So planting seeds early to get them thinking about that helps with breastfeeding success. One of the important things for tooth decay is an infant that is breastfeeding, number one, has to work to get the milk out of the breast. So it's an active suck swallow, as opposed to using a bottle where the milk kind of runs into the mouth and tends to sit around the base of the teeth. So you see less tooth decay once infants develop teeth if they're being breastfed. Another issue in the whole metabolic syndrome problem is that you get less obesity. The fat that an infant lays down when they're breastfed is different than if they're bottle fed. So even very chubby breastfed babies tend to thin out as soon as they begin walking, whereas bottle-fed babies tend to hang on to more of their fat. So you also get a proper nutritional balance for bone and tooth development. One study that just came out that was interesting is toddlers that are still nursing when you're getting 2 or 3 years old that are snack nursers. They'll go nurse a little bit and then run, and then they'll come back and nurse a little bit and run. Those children do have higher rates of decay. It's probably because of the frequent suckling that they get more milk that sits around the base of the teeth. There are some changes that can occur in the mouth in pregnancy that we all need to be aware of. One of the interesting changes, which is a hypertrophic change of the gums or of the mucous membrane, is the pyogenic granuloma. These will go away after the birth of the baby, so they don't need to be excised unless they're causing a problem. I'll show you a picture in a second of one that would be causing a problem. They can get big enough that they actually, the patient might be biting on them if they're coming from the gums. Also, you get increased blood flow to the mucous membranes as a result of the hormones of pregnancy that can make them a little bit more indurated, a kind of physiological gingivitis. That blunting of the papillae that happens with the increased fluids then can lead to frank gingivitis. And you can also get progression of caries due to the pH changes of pregnancy within the mouth and also with dietary changes. Some moms in early pregnancy have a lot of nausea. They might be drinking ginger ale, so they're having pop all the time. Those ladies may be more prone to developing caries and dental problems as a result of those kinds of diet changes with their pregnancy. There is a picture of gingivitis, and you can see the, you guys all know what this is, so better than I do. And right here you can see a real inflamed area right there. So the patients will complain of bleeding and pain. This is a pyogenic granuloma of the lip. These can also happen on the skin, on the fingers. And there's one of the gums right there. That one you're probably going to want to excise because that one's going to be trouble for the patient. So there are a growing number of studies looking at periodontal disease in pregnancy. And one study, it estimated that 15% of patients of childbearing age have periodontal disease. Now we saw numbers up to 50%, right? But that's all age groups. So in the younger population, you're going to have a smaller percentage. One of the studies that I was looking at, and we'll talk about it a little bit, was the Cochrane protocol. How many of you are familiar with the Cochrane Collaborative? Okay, a lot of physicians know about Cochrane. This is a group that comes out of Great Britain that does meta-analyses of medical studies. They have very strict protocols as to what studies they will include in a meta-analysis to make sure that we're getting really good data And then they have the power of numbers then by combining similar studies to get more definitive answers for some of the questions that we struggle with in medicine. So as I was researching for this talk, I found that the Cochrane Collaborative has a protocol in place to look at the treatment of periodontal disease in pregnancy to see if they can improve outcomes with appropriate treatment. There are a number of studies out there that are contradictory, but the ones that they are specifically looking at, the disease states that they're looking at in this protocol include preterm birth, preterm premature rupture of membranes, or what OBGYNs call PPROM, pre-eclampsia, post-cesarean endometritis, or infection in the immediate postpartum time, and preterm low birth weight. There was a consensus panel of the European Federation of Periodontology and the American Academy of Periodontology that concluded that periodontal therapy does not reduce overall complications of pregnancy. So we've got some conflicting studies out there, and the Cochrane Protocol is going to be looking at that to see if they can indeed affect those changes. Some of the things that you look at in studies is there may be a lack of causality. Does the periodontal disease actually affect the complication in pregnancy, or were these just two conditions that happen to be present at the same time? If there's shared risk factors, it's hard to know what was the cause of a problem, like smoking. Underpowered trials, small trials, it's hard to get good data from. And the treatment protocol may not have been adequate. We've heard speaker after speaker this morning talk about patients that thought they were taking really good care of their teeth and were seeing a dental hygienist on a regular basis, but it wasn't enough. If a protocol in the study is not intensive enough to meet the stage of disease, then you may not get the outcome that you're looking for. So all of these factors need to be taken into consideration if we're looking at the studies in this regard. Another question is, may the treatment need to begin before pregnancy actually starts to get an optimal outcome? Might that bacteria being present in the early pregnancy already start damage that can't be corrected by appropriate treatment later on? That would be a question. Also, there's concern that perhaps the periodontal bacteria may affect the vaginal flora. If it infects the vaginal flora and it's present there when you get the treatment in the oral cavity, it may not affect a change that could affect the pregnancy later on. I'm going to talk a little bit about the pathophysiology of preterm labor, what we know happens to have preterm labor occur. Progesterone in pregnancy is the hormone that quiets the uterus. It keeps it from contracting, which is what a muscle likes to do. Also, the uterine muscle is interesting in that the way it contracts is through what's called gap junctions for labor. The muscle will contract off and on all through a pregnancy, but it's when the gap junctions occur late in pregnancy that you get coordinated contractions that actually result in cervical change and the delivery of the fetus. So as long as the progesterone's present and the gap junctions are not being formed, you might have what's called Braxton-Hicks contractions, which are tightenings, but not actual change in your cervix. The cervical ripening then happens under the influence of prostaglandins, and you also get decidual membrane activation as a result of prostaglandin activity, which is a breakdown of the proteins in the amniotic sac that allow it to break and help to initiate labor. If there is an activation of the membrane that happens before term, then you can get the premature rupture of membranes without labor. So what we believe happens is with certain bacteria that are common in urinary tract infections, for example, because we know urinary tract infections is a huge risk factor for preterm labor. Those bacteria are particularly prone to producing those substances that break down the membrane and also are the prostaglandin precursors in the hormonal milieu of the patient. So with these bacteria producing these substances, then these gap junctions develop earlier than they should, and preterm labor ensues. There was a study that showed 4 times higher preterm delivery rate in patients that had severe or generalized periodontal disease, and a 7 times higher risk of birth before 32 weeks. So for those of you that don't do this all the time, we call term pregnancies anything after 37 weeks. We consider babies to be 100% viable at 34 weeks. Even though they're preterm and they need some assistance, they don't die because they're preterm. But between 32 and 34 weeks, you get about a 95% survival rate. Before 32 weeks, the earlier the baby is, the lower that rate becomes. So 34 weeks is that target that we kind of, okay, we made it here, but we like to get them to 37 weeks. So you can see that the very preterm, before 32 weeks, 7 times higher risk with the periodontal disease. Now, not all of the studies agree with this conclusion, which is why you got this collaborative that said, we don't think there's a connection. But knowing the connection between inflammation and preterm delivery, I have to believe that if we strictly define periodontal disease and we strictly define appropriate treatment, I think we're going to connect those dots. The urinary tract infections specifically have the bacteria that release the phospholipase A2, that's a precursor for prostaglandins. And then other infections around the uterus can cause uterine irritability. And uterine irritability, that's the uterus wanting to contract more than normal, is a risk factor for preterm labor. Cervical and vaginal infections, we believe, are huge players, and we've identified some of those. Bacterial vaginosis, which is Gardnerella, is one of those bacteria that has been shown to be more involved in preterm labor, and also in chorioamnionitis. That's when you actually get an infection within the uterine cavity while the pregnancy is still intact. That can be life-threatening both for the baby and for the mother. And then with periodontal disease, we need more studies to understand its effect. Systemic bacteremia is also a risk factor for preterm labor, and we know that with severe periodontal disease, you do get that bacteremia. If that bacteremia is treated, it seems to improve outcomes. This was a number of years ago, and somebody had a case report poster presentation. So I've not actually seen this case report in print, but I was very impressed that a patient had come in preterm labor with a very severe tooth abscess. She was so unstable in regards to her contractions that they decided to ignore the infection in her tooth and just try to treat the preterm labor. They were not successful in making her contractions stop. Now, I just want to add here that when we try to stop labor, we're giving medications, primarily magnesium sulfate, that can actually be life-threatening for the mom. One of the complications of magnesium sulfate therapy is pulmonary edema. Everybody knows it's not a good idea to have water in your lungs, right? So when we are treating for preterm labor, we recognize that we are also putting the patient at risk. We have to watch them very carefully, and we have to do a risk-benefit decision there about when to treat and when not to. So they were treating, but they could not get her contractions to stop, and her tooth was getting so bad, they decided they better deal with that anyway. They extracted the tooth, they put the patient on antibiotics, her labor stopped. Her cervix, which was dilating, closed up. I'd never heard of such a thing. The patient went to term. Now, if that's not a connection between inflammation and preterm labor, I don't know what it would be. But this was a very, very impressive case report of that direct connection between inflammation that had nothing to do with the pregnancy and preterm labor. Pre-eclampsia is one of these disease states that we've been trying to figure out for as long as physicians have been treating women. I heard that in the mid-1800s there was a $500 reward that was placed for anybody who would figure out the etiology of preeclampsia. I'm here to say that reward is yet to be claimed. Don't know what it would be worth in today's dollars. But when we're taking care of women, we're watching for signs of preeclampsia all the time. The definition is hypertension with proteinuria, so you have to have both of those things. We think about swelling. The swelling is not a factor to make the diagnosis, but most women have it because it's a protein losing condition, and that makes the fluids from the intravascular arena exit the vascular system and go into the tissues. So that's why you get all the swelling. It affects about 7% of pregnancies. And there is a full cascade of events that involve the cardiovascular system, the renal system, the hepatic system, and then the central nervous system, along with the soft tissues. Most researchers believe that the actual insult occurs at the endothelial level. Does this sound familiar? Heard anything about the endothelium earlier today? Boy, those are some real connecting dots, aren't they? So we think that that's probably where it starts, and that the damage actually begins probably about 20 weeks gestation, but doesn't grow and develop into something clinically evident until the patient gets more like in the third trimester, 32, 34, 37 weeks along. You get increased resistance of the cardiovascular system. That's what makes the blood pressure go up. And you can get elevation of blood pressures high enough to risk stroke. You get the loss of the proteins through the renal system. And you get elevation of liver enzymes as the disease progresses that can cause liver capsular swelling and actually can lead to death if the capsule ruptures. And then irritability of the central nervous system that can lead to seizures. So we call it pre-eclampsia before there are seizures. If there are seizures, then we call it eclampsia or toxemia. The theories of the etiologies include abnormal trophoblast invasion, imbalance in angiogenesis, coagulation abnormalities, vascular endothelial damage. That's where our periodontal disease probably could be a factor here. Immunology, genetic predisposition, an exaggerated inflammatory response. We've already heard about that too, right? That your genetic predisposition can be to react more strongly to an inflammation. And then increased oxidative stress. Now, does anybody know what this is? I heard one person say it. This is a liver. And this is blood clot and necrosis. This is what happens when the liver capsule ruptures during preeclampsia. And obviously, if we have this specimen, that patient didn't make it, did they? So this is it can be a very severe disease. So there are several studies out there that do link pre-eclampsia with periodontal disease. And the most interesting study, in my opinion, was one that actually looked at the bacteria within the placenta of patients that had pre-eclampsia. And they found the pathogens that are common in periodontal disease in the placentas of patients with preeclampsia. Isn't that interesting? Also, there are inflammatory markers that can mark the beginning of that cascade of events that we can watch that could start preeclampsia. Now, aside from preeclampsia, we also are concerned about other complications. I didn't find any articles in my research on chorioamnionitis. I heard it mentioned, but I did hear some other people at the conference talking about a patient that had a stillbirth, and they found one of the periodontal pathogens in the fetus, and that they think that there was a link between that patient's disease and the stillbirth of her infant. So it's possible that even before the delivery, those pathogens may find their way to the uterine cavity. After delivery, there was a study that looked at women who became infected in the uterus after a delivery. And those who had periodontal disease had a 33% risk of developing endometritis. Those without only had a 3% risk. So there seems to be a connection there. We know that bacteria can enter the bloodstream through the periodontal spaces. We know that after a delivery, when you have the raw surface area where that placenta was attached that is in a state of healing, that bacteria are attracted to that very rich source of damaged tissue as a place to set up. Another study looked not only at preterm birth, but infants that were particularly low weight at their time of delivery. And the risk factors that they looked at include level of prenatal care, parity or how many pregnancies a patient's had, genitourinary infections, alcohol consumption, and cigarette smoking, along with periodontal disease. So the question was it periodontal disease that caused low birth weight, or was it these other factors that might have been present along with the periodontal disease? And using the multivariate regression techniques to erase the effect of those other factors, they felt that periodontal disease was a primary and significant risk factor with odds ratio of 7.9. Now, I'm going to need my statistics partners here to really get at the bottom of this. But when they do these studies and they look at these factors, they can see if the periodontal disease rises as a primary issue. If you extrapolate that, then it's possible that as many as 18.2% of preterm infants with low birth weight may have been affected by periodontal disease. Now, we take care of women through their whole lifespan. So after they're done having babies, we often will do hormone replacement therapy as a treatment for osteoporosis. The picture here shows normal trabecular bone, and this picture shows osteoporotic bone. And you can see how you're losing your structural support of the bone that can allow this tissue to collapse and cause the compression fractures and potentially damage to the alveolar bone within the jaw. So there are studies that indicate when a patient has a condition of osteoporosis and she's treated with hormonal therapy, that also gives better health to the alveolar bone within the jaw as well. And so when we are talking about preventative health care with our patients, we can discuss oral health when we're discussing estrogen replacement therapy. Now, I did not talk about gestational diabetes. I know we're going to have some discussion of that as well. So when a patient's pregnant, they have, just as a part of the pregnancy, some inherent glucose resistance that, insulin resistance that makes them prone to gestational diabetes. And we can also connect the dots then with periodontal disease that may push that patient over the edge of the normal insulin resistance to a frank gestational diabetes in the case of patients that are affected. So, we as OBGYNs are in consensus that inflammatory markers and infections do predispose patients to preterm labor and other complications of pregnancy. There is evidence that bacteremia involved in periodontal disease can affect pregnancies, and treating that can improve outcomes. We are not sure of all the causes and effects, but I believe as we find out more about the inflammatory markers involved in periodontal disease, that we will see how we can better take care of our female patients by appropriately addressing those topics. I think we're going to find that patients who wish to become pregnant are going to be best served if they take appropriate care of their dental health before becoming pregnant. And we should always consider education on oral health as we're taking care of our patients. So we'll include the discussion when we're taking care of the women during their exams, and include visualization of the teeth and gums. Now, we already know that we're not going to see it all, right? So we're still going to refer the patients for regular dental maintenance exams. Also, I was introduced to a doc that took care of a large homeless population. They would actually pass out mouthwash because these patients didn't have a place to brush their teeth. He thought, well, at least I can give them some antiseptic care for the oral flora to help reduce their risks. And remember chronic disease and complicated pregnancy and looking at periodontal disease. And then always make sure that your patients have a nice smile. And I always like happy treated patients. Okay. I've got some references on here too if anybody's interested in those. Well, I thank you very much for your attention.